Great. So I'm going to focus on the use of diuretics. And before I came, I checked my electronic prescribing information for the ICU. And last year, my intensive care doctors prescribed 1,572 boluses of furosemide. So it's a very frequently implemented therapy. However, as usual, we have a limited understanding of why they did that, what they were trying to achieve when they did that, and whether, in fact, they achieved it. And so during this presentation, I will try to focus on what is known about intravenous diuretic therapy in the critically ill and acute kidney injury patients, hopefully provide some answers to these questions. The world of diuretics in acute kidney injury and intensive care have been relatively quiescent until Ravi and his group published a study linking the use of diuretics in patients with acute kidney injury with a greater likelihood of a poor outcome, a little bit the inverse of what you've seen with fluid accumulation. This, of course, is an observational study, but nonetheless, it linked hospital mortality with the use of diuretics, and it raised concerns about the use of diuretics to deal with fluid overload when perhaps renal replacement therapy as implemented by nephrology consultation may not actually be the right thing to do. We went on to have a look using the Best Kidney database, which is a multi-center study involving 23 countries and 54 ICUs, to see if this is a reproducible effect. And we looked at a population of about 1,700 patients. And we did a variety of statistical adjustments because clearly these patients who receive diuretics and those who do not receive diuretics will be different. And with these adjustments for a variety of risk factors for poor outcome, as well as doing a propensity analysis, we were unable to demonstrate that there was an association with greater risk using a propensity-adjusted mortality model, and then refining that further, and then adjusting for multicollinearity by the fact that a variety of items on this model are associated with each other. So it is possible that there is a harmful effect. The quantification of it is uncertain, and the association of it probably depends on centers, patient populations, and patient characteristics. In the world of acute kidney injury specifically, in terms of looking at randomized controlled trials, what you find is that there is a paucity of data to help us. This is one of the biggest studies, and it's very small, involving less than 100 patients, and they were able to show that in patients with acute renal failure or acute kidney injury, acute renal failure in the nomenclature of almost 15 years ago, there was an effect in terms of inducing diuresis, but there was no other significant clinically important benefit. Other studies, again, have been relatively small, 66 patients, 58 patients, again, showing that diuretics do have a diuretic effect, at least in a subgroup of patients with acute kidney injury, but not having the statistical power to be able to demonstrate clinically significant difference. And again, Shiley-Day study is yet another one with limited patients unable to demonstrate a clinically different outcome. So these have been meta-analyzed, as you might imagine. Sean Bagshaw was responsible to look at the entire literature, which is still very small, only 500 patients, and he was able to demonstrate that there was an effect on diuresis and maybe an effect on the duration of renal replacement therapy, but no clear evidence of a benefit in terms of patient-centered outcomes. A unique area where perhaps there's been a little bit more investigation is that of radiocontrast-induced nephropathy. And there is a well-publicized trial now almost 20 years ago by Solomon, randomizing patients to receive either saline or saline and mannitol or saline with furosemide, and identifying that the patients that had been treated with furosemide or mannitol had a more unfavorable outcome, and particularly with the addition of furosemide, a greater increase in serum creatinine in association with radiocontrast administration, which was statistically significant, suggesting that in this particular population, the addition of furosemide is not helpful. So it is in this background noise of what we do or do not understand about diuretic use in the critically ill, or diuretic use in patients with acute kidney injury, or in those with both critical illness and acute kidney injury. We try to understand the way people would report their behavior in Australia and New Zealand, which is where I work. And we conducted a survey through the College of Intensive Care Medicine in Australia and New Zealand, the Australian and New Zealand Intensive Care Society, and asked people why they felt they would prescribe diuretics. And as you would imagine, the most powerful triggers for the use of diuretics were fluid overload, and fluid overload involving the lungs, not necessarily fluid overload of the peripheral nature, but more central. So about 80 to 90% of clinicians self-reported that they would use diuretics for pulmonary edema, for acute lung injury with a sense of fluid overload, and for fluid overload on clinical assessment. Interestingly, a few, and not a small proportion, about 40%, also reported that they would use diuretics in the ICU to deal with oliguria without any specification whether that oliguria was or was not associated with fluid overload. And some dealt with central venous pressure with diuretics, and as you see there in acute kidney injury, very, very few would consider that as reason for prescribing it. And when we asked them, how would you do that? The administration of a bolus of intravenous furosemide was the preferred option. About three-quarters of the patients and three-quarters of the physicians reported that that's what they would use, and whereas continuous infusions were relatively uncommon. So it is not a surprise, given these preferences in Australia and New Zealand, that in my hospital, my colleagues would give 1,572 boluses of furosemide. They're just like everyone else in my medical binational community. The preferred starting dose is 40 milligrams. This is aided by the vials of furosemide, which if they contained a different dose, maybe 45, or had vials of 22.5 milligrams, then the preferred dose will be 45, and it is not adjusted to body weight. And it is stereotypical, and it is not adjusted to condition. So not adjusted to the degree of fluid overload, not adjusted to the perceived clinical situation, not adjusted to body weight, and not adjusted for anything, for that matter, which is interesting. The interesting thing from our point of view was also to ask them just exactly what was it that they expected to get if they gave diuretics. So I've said if you got a positive fluid balance and you gave a bolus of 40 milligrams of furosemide, which seems to be the common dose, what would you get? What do you expect? And they said, Lord, we will have a fluid balance that will be negative about 1 liter over 24 hours. The second most common is we got no idea what it is that we're expecting. And the third most common was 1.5 liters. And if you're oliguria, we would expect that you get up to about 1 mil per kilo per hour. Half of them will be contented with half that much, and the rest, well, a little bit more. We're not really sure what it is. And you can see that there is this incredible variability of goals and an unclear expectation of what to get that changes according to circumstances and preferences. And it is very undefined, very much like the rest of clinical medicine. So then we went and said, well, look, why don't we look and have a bit of a study and see what happens when you give a stereotypical dose of diuretics to critically ill patients in our ICU. And so we conducted a prospective observational study where we didn't tell the clinicians what to do. We just got the nurses to tell us when a clinician was about to give a bolus of 40 milligrams of Lasix, and we then decided we would have a look and see what would happen. So it's a small cohort of patients, quite a degree of heterogeneity in terms of their diagnosis, in terms of emission diagnosis, baseline creatinine and physiological characteristics, and whether they were or were not on chronic diuretic therapy, and also some variable stages of acute kidney injury and vasopressor or inotropic support. So a very heterogeneous population where the clinicians, for reasons that they justified as being fluid overload or oliguria or a combination of both, decided to give a diuretic dose. So, but this time we prospectively assessed what was going to happen to these patients, and we measured what was happening before the administration of Lasix, furosemide, and what happened in the 6 hours after the administration of furosemide. Of course, all of you would know that the word Lasix comes from the joining of lasts 6 hours. This is how it was created as a term. And so in these patients, the urinary output is not that low over the 6 hours before, and furosemide increases, and you see the difference is about 600 mils of urine over 6 hours, so an extra 100 mils of urine is excreted over that period of time. This is diminished if you are on a vasopressor infusion, but it's still substantial. And it is not particularly different if you're on long-term diuretics. If you look at the cumulative fluid balance, during that period, it is negative by about 600 mils, and there are no obvious discernible effects on the hemodynamics that we were measuring in these patients. When you try and look at what are the factors that are associated on a multivariable model with the response, the diuretic response associated with furosemide, you see that older age would decrease the response, the magnitude of the response. It's about 20 mils that you lose for every year of age that you go up. The mean arterial pressure is also a significant factor associated with the urinary output that you get by the administration of furosemide. And so if you have a higher blood pressure, you're more likely to have a diuresis than if you have a lower blood pressure. If you have a higher albumin, you're more likely to have less diuresis when you give furosemide. And of course, if you have a higher creatinine, you have a lower response to furosemide. And this provides some quantification. And these are effects that are visible only in 20 patients, so they must be quite substantial. And you can then measure the urinary electrolytes. And you can see that after furosemide, there is a significant increase in the natriuresis, in the chloruresis, and of course, there is a limited effect after furosemide in the amount of potassium that's excreted, which might come to people as a slight surprise, and not much of a change in magnesium. There's a consequence of the losses of chloride. There is hypochloremia in the 6 hours that follow, and the hypochloremia, if you believe in the Stewart explanation of acid-base physiology, changes the strong ion difference. And of course, that leads to an increase in bicarbonate and induces alkalosis, and indeed, in our patients, alkalemia. If you look at the mass excretion of sodium, you can see there is an increase of about 74 millimoles of sodium over 6 hours that quantifies that. And the chloride increase is very substantial after furosemide, much more than any other electrolyte, and there is a slight increase in magnesium and some loss of potassium there that is visible to all of you. The free water clearance is highly variable, and so you cannot predict whether the patient will become hypernatremic or not after the administration of furosemide in any reliable way. And this is a graphic representation of what happens when you give a bolus of furosemide to critically ill patients in a heterogeneous group of patients, and indeed it lasts 6 hours, and that's reassuring. And the urinary output change can be very different. Some patients have very limited increase, and some patients can have an absolutely prodigious urinary output of up to 3 liters over 6 hours. And again, it is very difficult to predict what's going to happen. And I'm just showing, again, the graphic representation of the variability in the mass excretion of chloride and sodium and potassium in these patients, and also the incredible variability in free water excretion, which would determine whether the patient becomes hypernatremic or not. Other people recently, again from Australia and New Zealand, have taken an interest in trying to understand the factors that determine the response to the administration of furosemide in critically ill patients. And in particular, they've used high-performance liquid chromatography to try and look at plasma furosemide concentration to see if it is a predictor of urinary output, and to look, as you will see in a minute, at urinary furosemide concentration. You can see here that there is quite a lot of overlap according to plasma levels of furosemide in these three tertiles of creatinine clearance, so that there isn't a clear difference in these groups of patients. But if you measure urinary furosemide and you look at its concentration or excretion in the urine, you can see that if you have very poor renal function, as measured by creatinine clearance, then you have a very low furosemide concentration in the urine, and there is a progressive increase as your creatinine clearance goes up. And of course, as you might expect, if there is no urinary concentration of furosemide, presumably there is very little concentration of furosemide in the tubules, and if there is little concentration of furosemide in the tubules, there isn't much urine coming out, which is obviously different from the patients where that concentration is higher. And if you look at the relationship between creatinine clearance and the total urine furosemide excretion, that is a pretty solid level of correlation. And so the furosemide excretion is significantly influenced by kidney function before its administration, and it is associated with urinary output, and there is a saturation effect, if you wish, when you get to about 7 or 8 micrograms per hour of furosemide excretion, which is displayed in this graphic format. And it gives you a more precise pharmacodynamic understanding of the relationship between your therapy, the plasma levels of furosemide, the urinary levels of furosemide, renal function, and the likely urinary output response. And unfortunately, this study did not focus on the electrolyte losses that would be associated with furosemide. So let me close by saying that loop diuretics are commonly prescribed in intensive care units. This is true in mine, and it was true in the Best Kidney study. They appear to be mostly prescribed for the treatment of fluid balance and for the control of it. They are typically prescribed in a stereotypical way that does not adjust the dose for the patient's age, for the patient's size, for the patient's creatinine, and for the patient's blood pressure and albumin. And therefore, there is great variability in different individuals, which is modulated by these factors. If you give furosemide as a bolus, it will induce changes in acid-base status, which appear to be due to the increased excretion of chloride, which in turn leads to alkalosis and a degree of alkalemia. In patients with advanced acute kidney injury, there is a limited logic to the administration of furosemide because urinary furosemide concentration is the major determinant of urinary output, and the urinary furosemide concentration in these patients is very low. And then, this still doesn't answer the question. If you wanted to take fluid off patients and modify their electrolyte concentration, we have no understanding of what is the best diuretic to achieve those, given that furosemide is just one of the many diuretics available to man. Thank you very much.